is Monday, it is 1 p.m. and yes, that's Pospo and Braincast for mostly learning all the way from exotic Camberwell in southeast London. I bet you can tell I miss my barber more than any other human being, as no scissors have graced his face for a few months now. Okay, that's an exaggeration. It's not an exaggeration, though, to say that addictions of any sort can be detrimental to people's lives. And this was the main topic of a passionate discussion with Professor Henrietta Bowden-Jones, the founder and director of the National Center for Gaming Disorders. So if you want to hear more about gaming addiction, head to YouTube or Spotify, as the recordings are patiently waiting for you. This week, we leave our PlayStations on the side and focus on what Matthew Broome described as the basic science of psychiatry. Psychopathology. With me, a man that, to be honest, no introduction would serve him right. Graduating with distinction from University of Ibadan, he trained as a psychiatrist in Newcastle. Head of Department of Psychiatry from 2003 to 2009, he is the Associate Editor for the British Journal of Psychiatry and on the editorial boards of BJ Psych Bulletin and BJ Psych Advances. He is author of a book you may have heard, Symptoms in the Mind. I'm pretty sure you have done, but also many others. As on his free time, he is a poet and literary critic. And if you think that's not enough, well, many people will disagree with you, as he received the Royal College of Psychiatrists Lifetime Achievement Award. Braincast people, Professor Femi Oyebode. Prof, welcome to Braincast.
Thank you very much, Pospo.
So, Prof, psychopathology, a synthesis of three beautiful Greek words: psyche, pathos, and logos, a term coined back in the 1800s by the German psychiatrist Hermann Ebbinghaus that, according to Anastasia Stodoridou paper in Frontiers, it roughly translates into teachings of the sufferings of the soul. And although, descriptions of what we now call neurological and psychiatric disorders were evident even in ancient Mesopotamia 4,000 years ago, they were all objective, as subjective accounts of feelings, thoughts, and behaviors are a relatively new phenomenon in medical texts. So why don't you take us on a brief history of psychopathology?
Thank you very much. I have to start off by saying I'm not a historian of psychopathology, so I rely on Hermann Berrios's views on these matters, and he, of course, said that the psychopathology as we understand it, descriptive psychopathology as we currently understand it, probably came into being in the mid 1800s, and he lists a number of names. He lists Pinel, Esquirol, Grisinger, Faure, Bayega, all these sort of people as having had started to formulate what we now understand psychopathology to be. But I think it's an indisputable fact that Karl Jaspers' codification of descriptive psychopathology in his 1913 book, which we all know about, we may not all have read it, General Psychopathology, essentially is the kind of seminal work which pulled together a way of thinking, which systematized it and allows us in today's language to speak across space, across the whole of the world, thinking about psychopathology in more or less the same sort of way.
And then, of course, Prof, there is phenomenology, from the Greek word phenomenon. And truth is that, although Heidegger perceived phenomena as internal, subjective experiences, in Greek, essentially phenomenon refers to outward appearance, which is pretty much how most psychiatrists approach phenomenology nowadays. According to Beaumont, though, this is not right. And in fact, Beaumont argues that phenomenology is a word actually much abused in psychiatry, and it has come to mean the objective description of the symptoms. So let's clarify this once and for all. So what is phenomenology and how is it linked to psychopathology?
Yes, I think that we'll probably come back to talk a bit about this business of objective and subjective, which is these are terms which bedevil psychiatry, really. But to go back to phenomenology, I think Husserl's idea was these are written in very complex, dense language, but I just take it to mean an opportunity, nothing to do with abnormal experiences, an opportunity to recognize that the contents of consciousness were worthy of study. So that, I think, is what phenomenology is all about. So the term itself just meant the phenomena that which I call the objects or the contents of consciousness, conscious awareness, that they're worthy of study. In other words, he wasn't necessarily interested in whether the contents of our consciousness, whether there were other things that underlay them. So he was interested, and so are we, interested in the nature of appearances. And we go all the way back to Plato to talk about it, about the distinction between appearance and reality. So Husserl's contribution was to say, he used the word bracket, and what he meant was, let's leave the sharp discussions about whether appearances are exactly what they seem to be, and let's just concentrate on the appearances themselves, because of course the objects of our conscious awareness are appearances. So he wanted to move away from that sort of approach where Plato's, we're not going to talk a lot about it today, but Plato's cave, for example. So Plato's cave is this metaphor for thinking about, people living in a cave and they'd never been outside the cave, and the shadows on the wall of the cave, they took that to be what things really were. And then one of them managed to leave the cave to go outside of it, and then realized that the things that were seen on the wall, they were illusions. So those are the appearances. And then when he came back into the cave, he then realized that his knowledge was very strange to the people in the cave, because they couldn't believe that the images they saw weren't exactly what the reality was. But of course, that discussion about the nature of appearances can go on forever, because even when he was out of the cave, what he saw was still an illusion, i.e. still appearances. So phenomenology brackets all of that discussion and says we leave that to one side and let's just discuss the nature of our perceptions, the nature of the objects of our conscious awareness. So that's where phenomenology comes in. And it is wonderful for psychopathology, because of course, what Karl Jaspers was doing was, he was then applying that approach to psychopathology. He was then saying the objects of the conscious awareness of our patients are worthy of study. And they're worthy of study because it allows us to classify them. It allows us to describe them. It allows us to find the boundaries between the different phenomena which occur in their conscious awareness. It also allows us, if we are brave enough, to see where the boundaries of those experiences are in comparison to normal experiences. So the link is between the method of exploring, valorizing, recognizing the value of the contents of our subjective experience and studying them, and being less preoccupied with whether they're independent markers which are objective in the world, and so on and so forth.
But Prof, according to the New Oxford textbook of psychiatry, descriptive psychopathology is based on, and I quote, an assessment of symptoms that is as objective as possible. That is, that the abnormalities found in the experience and behavior of the patient should preferably not depend on the individual examiner, the adherence to a particular psychiatric school, the methodology of exploration, the general theoretical attitude, positive and negative expectations, and even the psychological interaction with the examinee. How on earth is that possible? How on earth can a psychiatrist be so objective?
Well, I mean, with due respect to the author of the book and of the chapter, we all recognize the problems we have in psychiatry. There's a great desire to have objective markers, like our colleagues. We want to have a blood test which tells you whether somebody's got hyperglycemia, so therefore you can say they've got diabetes. And we will be very pleased if we were to discover there was a serum melancholia that you could, take a blood test and send it off, and so on. So you have objective markers. So I say that the term objective is, in that sort of setting, is serving a non-science function. It's trying to say something about how psychiatry is an objective, positive science, and that he takes seriously that that there is consensus. That's what they're trying to use the word objective for. But of course, we know that the experiences of our patients, it's not like a movement disorder. It is not like a tumor. It's not a bump. So it is an experience which is subjective. And our task is, and the wonder of it, the extraordinary wonder of it, is that you can talk to somebody and you then start to find commonalities across individuals, even though these are subjective experiences. Therefore, there's a way in which those experiences are akin to a lump and a bump, because you discover that the nature of the voices they hear, or the nature of the unusual beliefs they hold, or the nature of the experience of their bodies that they have, that these experiences are not idiosyncratic. In other words, there's commonality across individuals, not only across individuals, across cultures. Yeah. So that is telling us something. Even if we want to not use the term abnormal, what it's telling us is that these experiences are shared, and our task as psychopathologists is to find a way to describe them so that we can then talk to patients about these experiences in such a way that they can talk to us too.
And Jose.mascarenhas postulates in an older paper that it requires, as you said, a careful interviewing effort to extract the salient profile of the distress, and that essentially, the symptoms are not ready for use objects, ripe for the picking. And I have to say that, I do find myself wondering, obviously I'm not British, but I do find myself wondering from time to time if I'm doing the whole thing right. As the truth is that I'm never going to be as fluent as an English doctor. So the same way that a French doctor wouldn't be as fluent in German, and so on and so forth. So do you think that native speakers have an obvious advantage when it comes to descriptive psychopathology?
So the quick answer to that question is yes.
I didn't want to hear that.
The long answer is far much more complex. So the long answer is, so if you take somebody like me, my native language is Yoruba. So I'm a Yoruba speaker, and of course I speak English. I speak it as a second language. And I am, just like you, armed with the language world of another language world, which allows me to understand the ways in which language is built on concepts. So my usual example is to give the example of mood disturbance, and that if you speak English, you can, and you're American, you can ask whether somebody's feeling blue. But that's a completely nonsensical question to ask if you were speaking Yoruba, because that already tells you something, that you are using concepts of color to determine something, to represent something which is internal. And if you're British, you can ask whether the person is feeling low, and an English speaker thinks that it is as natural as it is to drive on, as we do in Britain, to drive on the left. It feels so natural to an English person to drive on the left that they're surprised that somebody else drives on the right and they haven't had an accident. And it's the same stuff, that when you say there's somebody feeling low, you think, how else could you describe it? But I'm a Yoruba speaker, and if you were to try and translate feeling low metaphorically in that sense into Yoruba, the person will look at you and laugh, because you don't use an ordinal marker, to determine where you are, to say something about how you're feeling inside yourself. So what I'm trying to say there is that being a native speaker is wonderful when you're conducting interviews, but being armed with more than one language is absolutely extraordinarily powerful, because it allows you to move between concepts that language describes, and that's not trivial. What I'm trying to say is that the concepts that are used elsewhere tell you something. Therefore, sometimes you can use that to make inquiries, even though that's not the way the person normally speaks, and so on. So yes, in an ordinary conversation, I'd say, yeah, I do agree that there's a facility of speaking in a language which you're born into, which you're suckled in, and which you use when you're most anguished, which comes naturally to you when you're having an orgasm. That language it fits into your body. It's organic and natural to you. And I have to admit that that language works well if you are a proficient user of, because not all native speakers are proficient users of their own language.
You're right. And of course, for many, though, including the patient, the first end point of any assessment is a diagnosis. So tell me, doctor, so what do I have? And the main way that, we reach a diagnosis in psychiatry, most times, is by a clinical interview. Now, in a 2014 BJ Psych article, Matthew Broom argues that if psychopathology is conflated with nosography, essentially with diagnostic classification, only those symptoms that are supposed to have diagnostic value will be investigated. And even Andreasen, back in the 90s, wrote that in the American Journal of Psychiatry that DSM, which is the classification system used in the other side of the world, and ICD-10 here, essentially has had a dehumanizing impact on the practice of psychiatry. So what do you think are the dangers of conflating psychopathology with classification systems and diagnosis?
Yes, so in general, I agree with Matthew Broom. So first of all, we need to make a distinction between psychopathology and nosology. So nosology is preoccupied with diagnostic criteria, is preoccupied with natural history of conditions, is preoccupied with factors associated with these conditions, risk, all this sort of stuff. And my own view is that we've had premature closure in psychiatry. And what I mean by that is the terms, the diagnostic terms, the nosological categories that we use, we came to them too early. And that these categories are, I think most psychiatrists, any thinking psychiatrist agrees that these categories are false, by which I mean there may be something hiding under the term schizophrenia. It's unlikely to be one condition. There may be something hiding under the term bipolar disorder. It's highly likely that it is a multiple set of conditions. Therefore, there's premature closure. Therefore, there's frustration in research because the groups that you put together are not necessarily homogeneous and they may differ all over the world and so on and so forth. So we agree on that. I think most psychiatrists, we know that we're only doing this for convenience. Now, psychopathology, in my view, and I use the term elemental, not elementary, because elementary implies that they're simple, elemental phenomenon. These phenomenon, they transcend everything else. So how people decide to put them together to form a diagnostic category is left to other people. Mm-hmm. And our problem with the kind of menu-driven kind of diagnostic approach, filling forms in and thinking that there, if you have 4 of that and 1 of that, you've got that and so on, is that it implies that we know everything there is to know about psychopathology, which is very, very, very definitely false. And it also means that trainees and senior people only ask after the things they've been told that exist, implying that psychopathology is like anatomy, that hallucination, an auditory verbal hallucination, is like a femur, that we already know all about it, when it's not true. And so my own personal preference is to, obviously, I've spent a lot of my life just looking at simple, very, very simple phenomenon and trying to understand them and trying to see how extensive they are and trying to see whether you can unpack them, and often we can.
In a 2019 paper by Anna Daly and Sean Gallagher, they argue that when it comes to psychiatry, there will still remain, much that goes beyond genes, beyond neurons and brain scans, and that, even if science was able to establish clear correlations between genes, neural states, and mental illness, what remains to be understood in every case, in every patient, will be the subjective experience of the person that we are examining. But time now for me to put my devil's advocate hat on and ask, does the subjective experience matter, Prof? So when you go to the doctor, you want to be treated. If you dislocate your shoulder, the only thing you want to do is put it back into place. So why would psychiatry be any different? So would psychopathology be irrelevant if we had biomarkers? Or is psychopathology the key to biomarkers in psychiatry?
I mean, there are 2 or 3 questions you've asked.
I know.
Take them in turn. I mean, the first thing is, like, the easiest one to answer is the biomarkers. You can't get to biomarkers successfully if you think you're going to try and do biomarkers for nosological entities that I've already described are problematic. And so we're likely to fail precisely because we're not dealing with homogeneous entities. So that's the first thing to say. Second thing to say is that you are not, even if the nosological entities were shown to be true, you can't get to them without speaking to the person. So you still need to do psychopathology. You need to do, understand the subjective experience of the individual in front of you. So you can't get away from the kind of the interviews that we do in order to understand another human being, and then to talk about the value of psychopathology itself, and to talk about the value, the importance of phenomenology in that discussion, and to talk about how empathy works in that context. So because the conditions that our patients have, these are not conditions that are to do with organs in the body. So what I mean by that is, it's easy for you to have a fracture and concentrate on the fracture because the disease or the problem you've got doesn't affect your person. Now, as subject, you're not going to get away from the fact that the disorders are disorders of persons. They're not disorders of the limbic cortex. They're not disorders of the dorsal front. They are even though, yes, they are disorders of the structures, but they manifest themselves in the person. Therefore, in order to come to some sort of understanding of them, you still have to have individuals who are willing to, who are properly proficient, who understand, have understanding, proper deep understanding, and have fellow feeling and affiliation for the troubled individual, who can sit with them and make the explorations that are necessary. So the disorders in psychiatry, they are always going to be disorders of persons, even when we come to know what the biology of them are.
So Prof, let's get a bit more practical then. So last year, you co-authored the paper titled The Phenomenology of Auditory Verbal Hallucinations in Emotionally Unstable Personality Disorder and Post-Traumatic Stress Disorder. So you're suggesting that knowledge of the phenomenology of hallucinations in non-psychotic disorders has actually the potential to inform future, more successful management strategies. So how so?
Well, I think there are there are 2 things to say there. The first thing about that paper is to indicate that discourse matters. And that paper, of course, because it's a paper, it has to be very cold and has to do the work like all papers do. But one of the things that comes out of that paper is that the way in which a person speaks about their experience is as informative as the experience itself. So one of the things it's telling you is, if you think you can know about delusions or hallucinations by giving a questionnaire, then you don't know anything about psychiatry. Because psychiatry, some of the decisions about the nature of the experience is revealed to you in discourse, which is why the psychiatrists, they are not prejudiced individuals. The psychiatrist sitting in a clinic can say, this person tells me that they hear a voice which is talking to them in the third person. But there's something about how they tell me that tells me it's different from when the person with schizophrenia tells me that. So what that's saying is that there's something about how the thing is described, i.e., there's something that occurs in the discussion, in the discourse, that informs you about differences. All right, so that's one level that we never ever really properly come to terms with in psychiatry. That's because a lot of people want to publish papers using standardized instruments. And I have nothing against that. I'm just making the point that standardized instruments are problematic because what is lost in translation is what is essential. So the next issue that you want to ask is, how does this business of the time we spend and the energies and all that, how does that influence management, treatment? And of course, obviously I'm a clinician and I see patients like everybody else does, but I haven't spent a lot of my energy worrying about whether the work I'm doing is going to provide better treatment. In a trivial way, it's going to provide better treatments because if you do the work properly, it will feed into how you determine what the categories are, and the categories will determine information about treatments and outcomes. So that's how I see it. But I need to say one final thing about this, that the empathic approach which Karl Jaspers promulgated, this idea that you are recreating in yourself the experience which the patient is describing, and then when you re-represent it in yourself, it gives you a notion of the boundaries of it, the nature of it, and so on, and then you check out with them whether that's right or not. Now that encounter, that clinical encounter, which is using this, and we're not using the term empathy as normally used in English. We're using it in a very technical way because the empathic approach, the method, is not a warm, fellow-feeling kind. It is a very cold approach to try to understand what is going on inside somebody. But one of the remarkable things about it is that the interest you show is very helpful to the person who you're interviewing.
Of course.
Because they recognize that you're properly interested, and that the things that they're saying to you, which can be shocking, that you can listen to it and hear it, and that you are not put off by it or anything like that. So that facilitates the interaction between human beings. And it is therapeutic in the quotation mark sort of supportive psychotherapy sort of way, because for the first time, people can talk properly about the experiences they're getting, and to talk to somebody who is not put off by it, somebody who not only is they're not put off, but they're properly interested. And we humans, we like people to be interested in us. So that, in my view, is a therapeutic kind of encounter.
But Prof, all this that you're describing, and I hate myself even before saying it, all this requires time, and time is money. So is phenomenology and descriptive psychopathology, as you're describing it, compatible with an outcomes-driven NHS where less and less time is spent during a consultation?
Yeah, so that's our dilemma, isn't it? What can we do? That's our dilemma. That we're living in the 21st century, and that we've got the rise of the neoliberal agenda, and that things that can be counted as the things that are worthy, and anything which cannot be measured is useless. So that's the world we're living in, and some of us are resisting that, and most of us who are clinicians, we ought to be resisting that, and those. So that's the world we live in. So we just have to recognize, but we still have to do the work we do and have a sense of personal fulfillment. So you have to do the work to the best of your ability, with all the limitations of time, with all the pressures of filling forms in, with all the difficulties that we have having to discharge people the minute we've told them what the diagnosis is and things of that sort. So those are the encumbrances or the limitations and constraints that we have. But nonetheless, in our hearts, the ideal is that we want to spend the time that is necessary. So that's the ideal that drives us, and that we want to feel that the person who we're seeing, despite all the problems that there are in the services, that we want that person to feel that they've been understood, because that makes us feel good that we've done our jobs properly. So that is our ideal that drives us, but we recognize the difficulties that surround us.
So Prof, before we close, you are the author of 3 editions of Seeing Symptoms in the Mind, one of the most iconic books in descriptive psychopathology, and a must for every UK-based psychiatry trainee. So from what I'm hearing, you're already editing the 7th edition. So yes. What can one add, in this beautiful book? It's already there. What can you add there?
You can add a lot. So, for example, if you take something simple like delusions. Delusions are not simple, but for speaking sake, say something simple like delusions. And at present, people think of delusions as if a delusion is one thing. And some people know already that I don't think it's one thing. And I'm not talking about whether they are primary delusions or secondary delusions, but that delusion is just a term like an abnormal movement. And nobody will think all abnormal movements are the same.
Yeah.
So my task is to try to understand what is it about delusions that makes them different. So if you take folie à deux, for example, so folie à deux tells us something about how you can have an abnormal belief, which is to do with persuasive communication. So that abnormal belief is the same as when we come to hold political views, or when we prefer a particular soap compared to another soap and we go out to buy it, or when we're preoccupied with a particular suit that we buy because it's got a particular brand. So the ways in which the folie à deux beliefs are held and how they're introduced and induced into the individual relies on the same mechanisms that we have when we're being persuaded to buy things. So that form of belief is completely different, even though it's abnormal, from a belief like a capgras, where the individual is coming to hold a view because there are cognitive impairments which are linked to their face processing abilities. Completely different, they're not the same at all. And then if you look at something like delusional jealousy, and delusional jealousy is built on completely different ways of imagining the world. So if you think of our ancestral past on the plains of East Africa 200,000 years ago, the interactions, the mating interactions and mating exchanges, and the desire for sexual exclusivity, and the desire for certainty about paternity has constructs in the brain. So delusional jealousy is sitting on that. So they're different things. So and they're probably different brain mechanisms underpinning all that, just as there are different mechanisms underplaying different abnormal movements. So there's a lot to be said in psychopathology that we ignore because the teaching is pretty poor. Some of the ideas are so complex, they're very difficult to capture in words. They're easier to talk about, just like I've done, but very difficult to write about. So there's a lot to be said.
Tough job, Prof. Braincast people, this is Professor Femi Oyebode. Dust off your psychopathology knowledge because it's here to stay. Not that you didn't know that, it's just that, sometimes we don't really talk about it. As so many other things in life, like, for example, inequalities, which is exactly what we will be discussing next week. Race and ethnic inequalities in mental health. With me, a professor of sociology at the University of Manchester and deputy director of the ESRC Center on Dynamics of Ethnicity, and a fascinating speaker, Professor James Nasru. Until then, Pospo and Braincast for Mostly Learning, over and out.
Thank you.